here with my good friend Deepinder Dhaliwal. Deep, we're going to be talking about something important. So there are, I mean, not to suggest for a second that you and I don't always talk about important things. Um, there are many conversations that I've had with people at this meeting and previous meetings about how to manage low cylinder and what the options are and the sort of gap between not treating cylinder and the lowest power toric lenses. That is the opposite to what you and I are going to talk about today. There is an upper limit to the amount of cylinder that can be corrected fully with intraocular lenses. So we should just abandon those people? What do we do?
Josh, first of all, thank you so much for inviting me to be here.
It wouldn't be a meeting without it.
Oh, well, you're very kind. This is my favorite part of the meeting, always. And I would like to discuss, these poor patients that have high preoperative corneal astigmatism and are ready to have cataract surgery. So we have options, but the most important thing is we have to figure out what type of astigmatism they have. They have a lot. It could be regular astigmatism. It could be irregular astigmatism. And we need to really understand what type they have, the quantity and the quality. So what I typically do is I examine my preoperative cataract patient, look at the ocular surface, and then first treat the ocular surface and any obvious causes for induced astigmatism.
Such as?
Dry eye, number one, Salzmann's nodules, pterygia, things like that. So or epithelial basement membrane dystrophy. Very, very common cause. And the key is to recognize it. So what you have to do is put a little fluorescein in, diffuse blue light, and look at the cornea with a nice broad beam, and you can see all the little irregularity causing the distortion. So what I do, if it's central irregular epithelium, we offer them superficial keratectomy, pre-op, and we'll go ahead and do that. And it's so easy to remove, a nice 6 millimeter, 7 millimeter zone of epithelium in the center.
How do you do that? I mean, I do ethanol delamination and then with Wexel take things off. Are you a scraper?
Never. I'm just a gentle debrider.
A coaxer.
So what we do is we actually, I actually like to test the epithelium with a Wexel. A dry Wexel can really show you how loosey-goosey all that epithelium is. And so what I do is I just start in the center and I kind of rotate that dry Wexel around, and almost you can create an epitheliorhexis.
Yeah. I know. Owe me a Coke.
Jinx, you owe me a Coke.
Yeah.
Okay, so anyway, so I do that, and then I use a PRK or a Maloney spatula and actually, just kind of truncate the edges.
Yeah.
And you can polish that off with a diamond burr or PTK, put a bandaged contact lens on.
Or nothing if it looks smooth.
Or nothing if it looks smooth,
Yeah.
but put a bandaged contact lens on, antibiotic steroid, and let the patients heal. Recheck the Ks after about 6 to 8 weeks, and then go ahead and assess what type of astigmatism is remaining. So the options are, on topography and tomography, you want to see, is this astigmatism regular? A lot of these patients with high preoperative astigmatism actually have some underlying form fruus keratoconus, right? We've all seen
Or
that.
genuine keratoconus.
Or genuine keratoconus, right? But yes, and they may have never known about this, right? They just they know they have a lot of astigmatism and didn't really know why. So we educate the patients, and basically, it's still okay to put a toric lens in those patients. The key thing that I ask my patients is, are you interested in wearing a gas-permeable lens or a rigid lens, scleral lens, post-operatively to get that crisp vision? And if some of my patients say, no way, I've never worn them, I'm never going to wear them, then it's an obvious decision. I'm going to put a toric lens in because that correction they're used to is similar to to their spectacles. And I always like to say you have two types of astigmatism. The toric lens is going to correct the regular astigmatism, and that irregular part is what you've been living with anyway, that little bit of blur, and it's okay. Now, if, however, they love that crisp, sharp vision, then, and they're motivated to wear a contact lens, then I avoid a toric lens because it's just so much easier not to put it in.
Yeah, no, that's a great point. While we're on the subject of measurements, we're not up to sort of therapy yet. Uh, every now and then, someone will come in with astigmatism that is completely regular and is completely high. And I know that if I put in the highest power toric lens, they're going to have enough cylinder left that it's going to be enough of an impact on their vision that they are going to question why they spent money on a toric lens. Okay, so we're not up to the therapy part. What I want to know is, can I even trust my biometry on that? I, in my practice, am not able to directly measure the posterior corneal curvature. So I'm measuring only anterior cornea, and I'm using cochnomogram or modified cochnomogram or something that is using that. Can I rely on that sort of stuff for patients with very high cylinder?
Well, in those cases where I think I'm not going to be able to correct all of it according to the formulas, etc., I just, full disclosure to the patient, I say, look, this is what we have right now. We put the highest toric in, and then I let them heal. And then post-operatively, we polish off whatever they have residual, maybe even just have them wear a thin pair of glasses,
Yeah.
right? I mean, or you can do laser vision correction or, astigmatic keratotomy. You have options. But intraoperatively, I don't say, oh, if they have 5 diopters of regular astigmatism, I don't say, well, we're going to put a T9 plus do LRIs at the same time. I don't do that. I just want to put it in, see how they heal, and then deal with refractive surgery later.
So how do you? I mean, you've talked about this a little bit now. What is your surgical plan for patients with high corneal astigmatism?
Regular or irregular?
With regular high corneal astigmatism, what is your? I mean, it may be what you just said. I
Yes.
just want to know.
Yes. So they have high regular corneal astigmatism. I love toric lenses. I think patients have excellent quality of vision postoperatively, and they're so happy not having to wear, thick spectacles anymore and have that astigmatism corrected inside the eyes is ideal. And again, if we can't, theoretically, if we can't get all of it, I personally feel like it's a stepwise approach. So I put the toric lens in, see what we have. Now remember, if it's with the rule astigmatism, that can be tolerated. That can be much more easily tolerated than against the rule. So especially if it's with the rule, high with the rule, I'll just put in the highest power toric and then see how they're doing postoperatively. And, I really believe in, kind of 20 over happy vision.
Yeah.
If they're functional, that's great. That's our goal. And, I love this saying, happiness equals reality minus expectations.
Yeah,
So to get
no,
it,
that's
it.
very reasonable. Okay, I have one more sort of patient that I want to bring up. I mean, maybe you've got other sorts, and certainly I want to learn from you. Patients will occasionally come in with astigmatism that is substantial, without any corneal pathology, and the astigmatism is not entirely orthogonal. How do you manage these patients?
So that non-orthogonal or that irregular astigmatism, we know cannot be fully corrected in glasses. So I talk to the patient and see, how have you been dealing with your optical aberrations, refractive error. And if they've been in spectacles all their life, I will say, well, we can, kind of replicate what you've had in glasses with a toric lens. and give them that option. If they are hardcore gas permeable or scleral contact lens wearers, then we have to have a discussion about their future. If they wish to continue to do that, to wear a contact lens that changes the curvature of their cornea essentially, then I typically do not put a toric lens inside their eye because it just gets more complex postoperatively. Patients that love their contact lenses for that crisp, sharp vision, that correction of their non-orthogonal astigmatism occurring with that contact lens cannot be paralleled with a toric lens inside their eye. That's just the way it is. So, if they say, hey, I'm good with that, let's just do whatever we can inside, and I'll be okay wearing spectacles, and I'll be okay with that little blur, fine. But if they want to have that crisp, sharp vision, that correction of their irregular astigmatism, then I personally feel it's just much easier for the patient to have a non-toric lens inside, and then they can wear their contact lenses. And I had a patient recently. He was an attorney, 71 years old, completely dependent on his gas permeable contact lenses for vision. He didn't even own a pair of glasses. Came in for cataract surgery and said, you know what? I want to see without glasses. I want that multifocal lens that, my neighbors had. And so we did the evaluation. He had EBMD, keratoconus that he never knew about at age 71. And so we had a lot of discussion with him. We did the superficial keratectomy first, then counseled him. He liked his contact, so we put a non-toric lens in. Post-operatively, he actually was very pleased with his vision in his spectacles. He was shocked because he was also highly myopic. So we corrected that part of the refractive error, and then he said, you know what? I'm actually surprised I can actually see reasonably well in glasses. Now, mind you, we did not put a toric lens in, and he's not wearing his contact lenses. So it was just, kind of a stepwise approach. And I think that at the end of the day, he knew that he has that option. He could go either way, glasses or a contact lens. Now, listen, if you do put a toric lens in a patient with keratoconus, it makes it a little bit more complicated, but there are bitoric lenses, et cetera, that you can use. But the fitting can be definitely more challenging.
By toric rigid lenses
Yes,
you're talking about.
yes,
Yeah,
yes,
no.
yes, yes.
And I knew that's what you were
Yes, yes,
you were getting. I didn't want to
yes.
get down in the weeds, but I see
Yes,
you.
yes,
You're
yes,
a very
yes.
granular person. We have to talk about things like this. Deep, this is really, really, really wonderful stuff. I'm glad that you brought it to us. And of course, the reason that there aren't IOL options is that this is a very small market segment, but they're still our patients, and we still got to do right by them. So I want to thank you for the erudition that you always bring, and your ever great generosity with your time.
It is an absolute pleasure. Thank you, as always, for including me in this amazing experience.